Hi there, it's Matt Walker here, and welcome back to the podcast, and welcome back to a very special episode. I am interviewing a stellar guest. The guest is Dr. Jessica Lunsford-Avery. She is an associate professor in psychiatry and behavioral sciences at Duke University School of Medicine. She is, by training, a clinical psychologist, and she researches and treats, a vast array of psychiatric conditions of epic magnitude in terms of their need for treatment. It ranges from things such as ADHD, mood disorders, and anxiety. Her work is, for me, groundbreaking and truly exceptional. And the work that we're going to focus on today is a topic that I have been asked to cover so many times by you folks, the listeners and the public. Although I know some about the topic, I wanted to treat it with the reverence that it deserved and get the world's leading expert here on this topic. That's who we have in Dr. Lunsford-Avery. We're going to focus on sleep and ADHD. Dr. Lunsford-Avery, Jessica, welcome to the podcast.
Thank you so much for having me.
It is an absolute privilege and a delight. So to start with, could you just give us an overview, perhaps, of you and perhaps a quick summary of your current research focus, at least as it pertains to sleep and ADHD, either in children, adolescents, adults? Expand as you would wish.
Sure. So, as you mentioned, I'm a faculty member at Duke University. I've been here about 10 years. And like many of us in academia, I wear multiple hats. My research program focuses broadly on sleep and mental health in children and adolescents, with the specific area of interest focusing on understanding how sleep contributes to daytime impairment in ADHD. Also a clinical psychologist who provides cognitive behavioral therapies to children, adolescents, and adults with ADHD.
As you can hear, folks, my goodness, what a need that is out there. And just thank you for what you do for those populations. A slightly different question, perhaps. I'm always fascinated when I'm interviewing my colleagues to learn about what was it that initially drew you to the field of sleep research, and particularly in relationship to sleep and psychiatric disorders and mental health conditions? Because, a mind like yours, you could go in any direction. I almost think of when I've read your work, how brilliant it is, and almost like an academic stem cell. You're pluripotent. You probably could have gone in any direction. Why focus on these areas in particular?
You are so kind, Matt. And I'm a clinical psychologist, so I actually love people's stories too. My first job after college was working as a research assistant at the National Institute of Mental Health. And I was working in a lab that focused on understanding brain mechanisms underlying pediatric bipolar disorder. And in that role, we brought in families from all over the country to participate in these studies. As the point person for these families throughout their participation, I spent a lot of time with them and was repeatedly struck by how concerned caregivers were about their children's sleep and their insight that the sleep problems seemed to be making the mental health conditions worse. So I remember a mom saying to me, "I fear a bad night's sleep for her. It means mania is coming." That was it for me. I heard the need for a better understanding of links between sleep and mental health, and I heard the families asking for help, and I never looked back.
What a remarkable story, in the sense that when you are a parent in that situation, I mean, in some ways, you're a scientist in the laboratory of this thing called the home, and you are constantly receiving these data points. And at some point, it becomes so obvious that there is something about sleep that can be the predictive force, or disrupted sleep in particular, that foreshadows and almost with high certitude predicts an oncoming psychiatric condition, here particularly mania. Isn't that remarkable that it's that powerful, it's that obvious?
It is. And I think that caregivers do have so much insight. As providers, we interact with children and families, maybe once a week, once a month, but these parents are there every day. And so they're seeing, and every night. So they're seeing all of these relationships and are really able to often talk to us about it.
And speaking of that night, tell me a little bit more. And I know we're going to get into some of the real details about exactly how ADHD impacts the nuanced sleep features, but at the higher level, at a sort of a higher contour, tell me, how does ADHD in children and adolescents impact the general sleep patterns at that 30,000-foot level?
Yes. So concerns about sleep patterns are incredibly common in ADHD, reported by up to 80% of children and their caregivers. The most common ones are difficulties falling and staying asleep and poor sleep quality. Kids with ADHD also often have inconsistent sleep patterns, varying day to day in sleep timing. Whether ADHD is causing the sleep problems or vice versa is a bit tricky. Like many things in science, there's a chicken and egg problem there. But it is likely that ADHD symptoms do impact sleep patterns to some degree. So, for example, children and adolescents who struggle with organization may have difficulty adhering to consistent bedtime routines and schedules. Children with ADHD are also at risk for oppositional behaviors, which can increase bedtime resistance, for example.
That's very interesting. I was going to ask you a little bit about that timing, that consistency, that word consistency. So
Mm-hmm.
before that, you were saying children with ADHD, and I'm sure parents out there will resonate with this, difficulty falling asleep, then also difficulty in staying asleep, which would be sleep maintenance. But it's not
Mm-hmm.
just those two things. It's also about that regularity of sleep. And what you were saying there, I was at first jumping my mind to the idea of the condition having an interaction with the circadian rhythm, which dictates where we would like to sleep and where we would like to be awake on the 24-hour clock face. And maybe there's an interaction there innately, biologically, with the circadian system. But what you were describing was fascinating. There's also behavioral and external forces, such that there is resistance from the child sometimes to engage in that consistent behavioral activity. So that inconsistency of sleep timing is not just about biologically, perhaps a circadian interaction. It's also about the external behaviors of the child themselves and also the environment in which they're sleeping. Is that also the case? Do I have that right?
So, absolutely. In ADHD, when we think about inconsistent sleep patterns, there probably are multiple contributors, both biological and behavioral. On the biological side, certainly there may be a concern about something like circadian rhythm. And then on the behavioral side, there are also symptoms of ADHD, which may also contribute to that inconsistency.
Got it. Okay. My goodness. I mean, thinking of all of those challenges for parents, it's not just that the child, if you can get them to be in bed, they're already facing challenges with falling asleep, then waking up and having a challenge to fall back asleep. You've also got to try to manage this consistency, this regularity. What a challenge. But maybe if we could then double click on sleep specifically, and the listeners of the show will remember there are obviously many different stages of sleep. We've got non-REM sleep and we've got REM sleep, and non-REM sleep, we can break it down into these sub stages of lighter non-REM sleep and then deeper non-REM sleep. And during deep non-REM sleep, we get something called slow wave sleep or slow wave activity. And those are those big, powerful, slow brain waves during deep non-REM sleep. Tell us a little bit about the work that you've been doing, which for me has just been absolutely fascinating, trying to separate out what stages of sleep are changing in adolescents with ADHD, and what have you found in terms of the differences in different sleep stages?
Yeah, so in my study, we were specifically interested in assessing whether the amount and overnight pattern of slow wave activity differed between medication free adolescents with ADHD and those without the diagnosis. When the sleep system is working as it should, we expect to see a lot of slow wave activity at the beginning of the night, and then it tapers off steeply over the course of the night. In some of our prior work, we had shown abnormalities in the overnight pattern of slow wave activity in adults with insomnia, in which they had less slow wave activity at the beginning of the night and a more gradual, slower taper over the night. Given how important we believe slow wave activity is for refreshing the brain and body and for supporting cognition and learning, we wanted to see if there was a similar process happening in ADHD.
And so, could you, for the audience, maybe say a little bit more about this notion of tapering off of deep slow wave sleep? Again, people listening, if they're regular listeners, they will know that deep non-REM sleep is not distributed evenly across the night. In fact, you get most of your deep sleep perhaps in the first half of the night, and then it gradually sort of throttles back. And then REM sleep becomes the more dominant phase in the second half of the night. And it's this sort of almost like a sort of a ski slope as it gradually comes down in terms of that deep sleep across the night. So it's not just that we look at the amount of total slow wave sleep that you have or the slow wave activity that you're having. We also look at how it almost dissipates and sort of decreases across the night. And I think that that's the tapering notion that you were beautifully describing there. Could you maybe say a little bit more about how you think about this tapering off, this gradual decreasing amount of deep non-REM sleep across the night, and why that notion of tapering perhaps is important, and why it would lead you to think, I want to look at that in people with ADHD?
When we think about this taper of slow wave activity, we think about this as a marker for homeostatic sleep drive, or that pressure to sleep that builds over the course of the day the longer that people are awake. And so when that homeostatic sleep drive is really high, which is what we want when people are going to sleep, then we see a lot of that slow wave activity right at the beginning of the night. And then we do see that decrease or that taper across the night, whereas you say that slow wave activity decreases. And as we move toward morning, we're seeing more of that REM sleep. And so when we think about homeostatic sleep drive as it may possibly relate to insomnia, so I mentioned we found a similar process in adults with insomnia. When we hear that adolescents with ADHD are having difficulty falling asleep and difficulty maintaining sleep, it makes us wonder, do they have a similar process that may be happening as what we see in adults with insomnia?
That's lovely. Thank you for that in terms of description. And it's almost this notion that as we sleep, we evacuate, we sort of jettison all of that sleepiness that's been building up. And the evacuation of that sleepiness essentially is what we measure by this taper, this decline, this dissipation in deep sleep across the night. That is almost a marker for us in sleep science to show how well are you, in some ways, what we call discharging the amount of that sleepiness that's been building up across the day. And if you discharge all of it effectively, then you should wake up feeling refreshed and alert and awake without any of that lingering sleepiness weighing you down the next day. And therefore, that notion of the sleepiness that's been building up across the waking day and then the evacuation of it across the night, if you are not sleeping well, you're struggling to fall asleep, and you have issues of waking brain function across the day, this is not a bad measure to start looking at. It's actually a very sensible measure mechanistically. If that's the case, then tell us, how does the characteristic of deep non-REM sleep, slow wave sleep, how does it differ then in individuals with ADHD? And what have you been finding in terms of slow wave sleep relative to control participants?
We found that adolescents aged 13 to 17 with ADHD had less overall slow wave activity than adolescents without the condition. In addition, we found that the amount and pattern of slow wave activity, so this taper that we're discussing, was also related to cognitive performance for these adolescents. So, similarly to what we have previously observed in adults with insomnia, we again saw in our ADHD adolescent study that reduced slow wave activity and a more gradual, slower decline in slow wave activity over the night predicted poor cognition the next day.
My goodness. And what I like about that part of the research that you've been doing is it not only tells me descriptively and from a characteristic point of view, what is the difference here in slow wave activity? And what you were saying there is that firstly, there seems to be less of this slow wave activity in children with or adolescents with ADHD. It also takes longer for that evacuation, that discharging of the sleepiness. The system doesn't seem to be as efficient or facile in terms of evacuating out that sleepiness that's been building up across the day. But the reason I also found that part of the research fascinating, you could say as a scientist, if you describe that, four classical words of obnoxiousness, which is yes, and so what? Okay, it's different, but is it epiphenomenal? Does it actually matter? Just because it's there doesn't mean that, it's like the redness of our blood. There's no function of the redness of our blood. It's just what happens when light interacts with the blood cells that we have to produce the way that we perceive these light frequencies as red. So it could be completely epiphenomenal. But no, what you're saying is that the degree of the deficit in slow wave activity, both either in the amount or in that tapering, was predicting something about the waking brain function and particularly the cognitive abilities of those individuals with ADHD. And all of a sudden, if that's the case, you have to give it much more credence in terms of being not just something that is present and seems to be different, but is present, is different, and maybe consequential to the individual. And therefore, if it's consequential, you should maybe think about what would happen if you could manage it and treat it. Do I have that right as an explanation there?
Yes, exactly. And so when we think about some of the challenges that individuals with ADHD care about and want to be going better, I think often cognition is something that, individuals want to feel like they're thinking clearly, they're thinking quickly. And so what was interesting is that we actually found that this pattern in slow wave activity was related to cognition, whether we measured it subjectively, so asking the adolescent about their daily cognitive functioning, and also when we measured it objectively using computerized tasks of cognition. In both cases, whether we're asking them or we're measuring it objectively, we see this relationship with slow wave activity.
For those who struggle with sleep, one recommendation that I've often offered and I've written about in my book is meditation. Now, up front, I was a complete skeptic. I thought it was all just a little bit, but the data was really strong. So I tried it, and that was 7 years ago. And I've now been meditating for 10 minutes before bed every night. The app that I've been using is called Calm, and I've decided to partner with them here on this podcast. And Calm have agreed to offer a full 40% off its premium subscription service to you, the listener. And to get that 40% off, you can just go to calm.com/Matt Walker. So again, that is calm, CALM.com/Matt Walker to get your 40% off. So give it a try. See what you think. That's actually quite fascinating because what it would suggest is that the objective measures of sleep that you are acquiring as you're measuring with electrodes on the head that, of course, participants are completely unaware of, despite that objective measurement being non-conscious to the participant, it still is predictive of something when that individual wakes up that they are themselves very subjectively aware of, meaning that you can do some fancy tests, and of course the sleep may be predicting those sensitive fancy tests, but in some ways you could argue, wouldn't it be most important if the measurements that you were getting during sleep were even predictive of the difficulty that those individuals, they themselves perceive that they are having during the waking day. Because in some ways, you could argue, isn't that just as important as demonstrating on a computer test that they're not performing well? It's their own sense of the challenge that they're having with their mental cognitive function. That's fascinating to me.
Absolutely. And I think that that piece, the individual's perception, in a lot of ways, that is what's important. When we think about the symptoms of ADHD, such as inattention or distractibility or forgetfulness, these are behaviors that come up for all of us at some point in our
Yeah.
day and in our lives. But what makes this constellation of symptoms ADHD is the impairment that the individual experiences. So that these symptoms are coming up at a frequency and a severity that are bothersome to the person. And so I think really when we're thinking about treating ADHD in general, whether we're thinking about treating sleep or not, we're really wanting to treat what the person perceives as being hard.
And I think this is heartening for parents too, because when they would bring the child or the adolescent to you, in some ways, this is what they want to hear. And this is why I think you are so unique and powerful in this way. And I know obviously many of our colleagues are doing this too, which is you're so aware of what it is that they face, because what they face is not a computerized test and a set of standardized metrics that we read about in a scientific journal. They're faced with trying to say, can you help my child? Because my child is telling me that they are struggling and they are having a problem. And it's this subjective sense of what the child is telling the parent that the parent is really wanting the clinician to focus on and treat. And so if you're finding something in sleep that is sensitive to that, then my goodness, everyone needs to pay attention to this issue in sleep if it's mechanistically related. Speaking of mechanistic notions, what would be the mechanistic implications of these findings in terms of understanding the relationship between the quality of sleep that the individual is having and their ADHD symptoms?
Great question. We have hypotheses, but no definitive answers yet. As we were just chatting a little bit about, this pattern of slow wave activity over the course of the night is believed to be a marker of homeostatic sleep drive. And so we wonder when we see this reduced slow wave activity and we see this slower, more gradual taper in slow wave activity overnight, we wonder, if this may suggest that there's a deficit and perhaps the buildup of homeostatic sleep drive, which in turn could lead to lighter, less consolidated sleep, and then consequently poor daytime functioning. One hypothesis, however, we need additional follow-up to really substantiate and understand the mechanisms.
It's so interesting because, in some ways, let's do the thought experiment for a second that this is relevant and perhaps even, if not associationally relevant, which is what we're talking about here, but perhaps even causally relevant. If there is something about this deficit in the brain of someone with ADHD to build up sufficient sleep pressure across the day, and then furthermore, not be able to discharge and cleanse the brain of that build up in sleep pressure across the subsequent night. And that slow wave deficit is something that you've quantified, then what are the potential therapeutic implications of your research when it comes to slow wave sleep in treating or managing adolescents, and any interventions or treatments that you think could be developed based on your findings? I'm sure that's going to be a question that parents now learning about this information are instantly going to be asking.
I think that findings from our study may suggest that adolescents with ADHD and sleep problems may benefit from behavioral sleep interventions, such as cognitive behavioral therapy for insomnia or CBTI. In adults with insomnia, CBTI, and particularly the component of the intervention that involves time in bed restriction, has been shown to impact the patterns of slow wave activity that we have observed in our study of adolescents with ADHD. Separately, there's an emerging literature suggesting behavioral sleep interventions improve both sleep quality and ADHD symptoms in youth with ADHD. Although right now, we don't know whether those improvements are due to a treatment effect on slow wave activity. No one has looked at that possibility to date, but I think personally, it'll be a really important thing for us to examine and understand in the future.
And parents shouldn't get disheartened by the fact that we don't quite yet know if some of these interventions are changing the differences, the abnormalities that we've been discussing in slow wave activity. Because what you were describing even before that is there are behavioral interventions that are well proven, and you've used a lot and developed a lot of these measures yourself in the realm of something called cognitive behavioral therapy, and particularly focused on issues of sleep challenges. And we've spoken a lot on this podcast before about cognitive behavioral therapy for insomnia. So I think that that's a helpful thing for parents to know, that if they want to speak with their pediatrician or their doctor, they could always ask to say, look, I wasn't aware of it before, but I am now, that there are these cognitive behavioral tools that have been developed that seem to help with the sleep of children like my own and the ADHD sleep difficulties. Is that a reasonable thing to say, and a reasonable suggestion that if parents were curious about that, that it may be worth them having a conversation with the medical team?
Absolutely. So, as you mentioned, behavioral sleep interventions such as CBTI have a lot of evidence to suggest that they are effective in improving some of the sleep difficulties that we see in ADHD. And from the literature in adolescents in general, we have studies showing effectiveness of CBTI for improving insomnia symptoms. But there really is this emerging literature in ADHD specifically, saying that these interventions can improve sleep quality, which is in itself important. 80% of families are telling us that this is a problem and they want help with it. But there's also this initial evidence that it seems to be helping ADHD severity as well. And so when these sleep problems are present, I think it's certainly worth a conversation with a provider around whether CBTI might be something that can be helpful here.
Considering, as you said, I was going to come straight back to that. I mean, 80% is, and if you to tally up the number of families and children that are struggling with the condition of ADHD, and 80% of them are facing these challenges in sleep, anything that could help would not only help the child themselves, but I think we also need to remember that the parents are caring for that child. They're the
Mhm.
essentially first responders at night. There isn't anyone else. And so if you are able to try to regularize and help normalize and improve the quantity and quality of sleep in the child, you're also going to have a rosy afterglow effect on the parents themselves, because they're probably not sleeping well either, which only has manifold consequences for them and their caring of their child, I presume.
Absolutely. And so we do think that there are bidirectional relationships between parent and
Mm.
adolescent sleep. And so if your child is not sleeping well, certainly it can have a big impact on the parent's sleep as well. And then how well that parent feels that they can respond to the challenges the next day, both in their own lives and as parents.
And maybe if I could come back to the 30,000-foot view, another question that I'm sure many parents would be asking at this moment, particularly if they have maybe a younger child with an initial diagnosis of ADHD, what would you say in terms of the potential long-term impacts of sleep disturbance in children at risk for ADHD? And I'm not asking that question to try to scaremonger or to create concern or fear for parents, but I do think it's an important question to ask. What does science and clinical sleep medicine know about those potential long-term consequences of sleep disturbance in children at risk for ADHD?
Sleep disturbances are risk factors for a range of negative health outcomes, which happen to align with adverse outcomes we commonly see experienced by those with ADHD. For example, over the life course, individuals with ADHD are at elevated risk for things like depression and anxiety, suicidal ideation, substance misuse, obesity, and driving accidents. Although I'm not aware of a body of work specifically examining the role of sleep in these negative ADHD-related outcomes, my hunch, given both the prevalence of sleep problems in ADHD and what we know about sleep and adverse health problems in the general population, that sleep could be playing a role here. And perhaps sleep interventions may be able to improve prognosis for ADHD in a variety of ways. And I think that's an exciting possibility, that treating sleep may be able to help a variety of these outcomes possibly go a bit better.
And that would be in and of itself such a contribution to say that due to that higher risk, if you can build in and bake into the regimen of care of your child this notion of sufficient and good quality of sleep, you would maybe cloak that child or your child with some degree of greater resilience, greater immunity. It's sort of almost like this sleep Teflon jacket, where as a consequence, you can perhaps de-risk and bend the arrow of potential psychiatric condition development down on itself simply by trying to focus on sleep as a core component of stepping back those children from that more dangerous edge of psychiatric illness and vulnerability. That sounds Herculean in terms of its consequence to me.
Yeah, so again, I think you were mentioning, certainly not to scare anyone, there's a lot of differences in how ADHD presents for people and how it looks over the course of their life. But given this elevated risk of some of these really concerning health outcomes, if sleep can play a role in helping some of those trajectories go better for an individual, I think that's really important, and we should be looking at that and seeing if we can help children and adolescents sleep better so that they can have those additional benefits as well.
Perhaps a slightly different orthogonal set of questions now. One of the things I'm always interested in is not sleep myths, but things that perhaps folks may be believing about sleep that aren't necessarily true. And it's wonderful to try to help the public course correct some of those myths. In your work, what are some of the common misconceptions about ADHD and sleep that your research has been addressing? And I know that we'll come on to issues of medication in a second, which is in some ways the third rail, the sort of the lightning rod that we've not yet discussed, and we are going to discuss that for folks listening. But is there anything front and center in your mind based on your extensive experience in terms of patients or children and parents and misconceptions in that sleep ADHD equation?
I think that when a lot of people think about sleep and ADHD, they tend to assume that children and adolescents with ADHD are sleep deprived or have shorter sleep duration. And this leads to the recommendation of going to bed earlier and attempting to get more sleep. We did not find any differences in sleep duration in our study between adolescents with and without ADHD, which actually aligns with recent meta-analytic work, which has similarly found no consistent evidence of shorter sleep duration among youth with ADHD. It's not to say that there aren't some children with ADHD who are sleep deprived, but I don't think we should always assume that that is the problem. Rather, our results regarding slow wave activity patterns could suggest an insomnia-related process, in which case trying to go to bed earlier and then lying awake in bed but not sleeping may actually make some of the sleep problems worse.
And I think this is, to me, one of those very clear demonstrations of the importance of the work that you do, examining not simply just the quantity of sleep, it's also about the physiological quality of sleep. And in neurology, there's a condition called hemi-neglect. If you have a stroke in a certain part of the brain, you almost ignore one whole half of the world in terms of your perception, hence hemi, half, and neglect, meaning that you're not seeing that component of the world. And in some ways, I think that's one of the genius parts of your work, is that you're not just focusing on, is it quantity? Is it the amount of sleep? Because if you did, you would be missing, you would be suffering from this empirical hemi neglect. And if only you had measured the other side of that coin, which is sleep quality, you would have found this fascinating relationship of deficits in deep slow wave sleep, which are predictive functionally of some of the cognitive changes. And so that's why I think it's a great thing to get out there as a message, which is to say, well, yes, as a parent, my child maybe seems to sleep just as much as my first child who doesn't have ADHD. And so I don't really understand. Maybe sleep is not the problem. Maybe one shouldn't jump to that conclusion simply on the basis of duration, because what we're hearing from you is that there is quality of sleep concerns that you may not pick up if all you're focusing on is quantity of sleep. A sponsor of today's podcast is BetterHelp. As someone who has dedicated several decades now looking at the relationship between sleep and mental health, I know scientifically taking care of your mind is just as crucial as taking care of your body. It's the foundation of everything that we do with our minds, not to mention that your sleep health and your mental health are so powerfully intertwined. You can't have one without the other. Therapy can be an incredibly powerful way to support that foundation of mental health. This is where BetterHelp comes into play. I see it for anyone who wants to grow or learn and really just become the best version of their mental health selves. If you have been considering therapy, BetterHelp offers a flexible, convenient way to start. It's entirely online. You can fit it into your schedule no matter how busy you are. All you need to do, fill out a questionnaire, and you'll be matched with a licensed therapist who is right for you. You can switch therapists at any time without any additional charge. I think that's really important too. It's all about finding the right connection with your therapist. Please visit betterhelp.com/Matt Walker, and you will get 10% off your first month. Thanks again to BetterHelp for supporting this podcast and the sleep education mission that we are on. I'm really proud to support them. I think mental health and therapy is just an incredibly powerful, underutilized tool. So again, betterhelp.com/Matt Walker.
You know, I think there's a reason that we often focus on duration and sleep quantity. It's fairly easily quantifiable. You know, did you sleep 8 hours of sleep? Did you get 9? I think it's easier in some ways to wrap our mind around that. But this issue of sleep quality, as you're saying, I think can often be equally and sometimes even more important, but it is more difficult. You know, we're talking about slow wave activity patterns, a little bit more difficult maybe for parents to quantify, but as we're seeing, very important for this group and for this cognitive functioning that they're having the next day.
So maybe I can come on then to the proverbial elephant in the room. How do ADHD medications impact sleep? And of course, folks have heard me say this many times on the show, but tell us a little bit about the scientifically descriptive and obviously not medically prescriptive advice that, and information perhaps is a better word, but also maybe advice for parents of a child and those adolescents with ADHD. How should we all think about this equation of ADHD medications and sleep? Because there's so much social media stuff out there. Help us course correct. Give me the truth.
Well, the relationship between ADHD medications, which are often the stimulant class of medications, and sleep is complex. And there is a lot of variability across individuals with ADHD in how much medications affect their sleep, if at all. In general, when first starting a stimulant medication, there is a risk of greater difficulties with falling asleep. This is a fairly consistent finding in clinical trials of stimulant medications. However, for many, the effects of medications on sleep are mild and resolve over time. And interestingly, there is some evidence that stimulant medications may result in more consolidated sleep with fewer night awakenings, which can be a good thing. The bottom line is starting a stimulant medication may increase insomnia symptoms initially. Often this resolves over time, but how a medication impacts any given child's sleep likely depends on individual characteristics of the child.
I think this is such a critical message to get across because what I've heard many times or seen many times on social media is that these things will obliterate your sleep. They're desperately disruptive. It's a conspiracy, all of this. So it's not just great to learn of these myths that we're busting here, but also expectations. I think one of the challenges for a parent of a child that is newly diagnosed with ADHD is going to be, what should I expect here? What is coming down the road at us right now? And just understanding the information that you've provided, I think really helps manage expectations and set a context of expectation. One of the worst things that can happen with our own health, and especially the health of our children, is the issue of a question mark. The not knowingness, the unknown is really quite a concern. In some ways, can sometimes be quite frightening. So thank you for managing us with expectations based on information. I think that's hugely, hugely helpful, or at least it is for me. What then, and maybe we've already answered this question, but is there anything that you would like to add in terms of advice that you would give to parents of a child or an adolescent with ADHD concerning medication, and also just more generally their sleep habits? Any additional sort of things that you would say or that you do typically say in clinic?
Yes. So you and I have been talking now for a bit about just how important sleep is to daytime functioning. And so I always suggest that parents monitor their children's sleep, particularly when starting a new medication or changing the dose, and to communicate with the prescribing provider regarding any concerns about sleep disturbances that seem to be persisting over time. So, a medical provider can help families weigh the pros and cons of a medication and may be able to help optimize the dose or the timing of a medication to try to maximize the clinical benefit for ADHD symptoms while minimizing a negative potential impact on sleep. Behavioral sleep interventions or sleep aids such as melatonin may also mitigate sleep problems associated with stimulant use. The important thing here is communication with the medical provider who can help the family sort through these options and decide with the family what is best for the individual child.
If parents were going to take on this, I think, so important challenge of, as we start a new medication, let's just keep an eye on sleep. Is there anything that you would recommend, any tools or any specific questions that you would say, okay, here's, if you're going to create a spreadsheet, which is my nerdiness, or you're just going to kind of grab your little notebook and say, write down the dates all the way, one line to the next, to the next, to the next. What is it that they should be tracking in terms of the sleep, and any suggestions as to how they could do that best?
So certainly providers could give families something like a sleep diary, where we ask families to track, how long is it taking the child to fall asleep? How long are they sleeping on a night-to-night basis? And so we can certainly think about tracking, even somewhat formally, sleep after starting a new medication. But I also think it's really important for families to be tracking the daytime sleepiness and that daytime functioning as well. And so you and I were just speaking about this whole idea around quantity of sleep and quality of sleep. One way that I think about it is that we want to be tracking how the sleep is going at night, but we also want to be tracking how is it going during the day? What's their sleepiness? Is that getting better or worse? How's their cognitive functioning seem to be going? Is that getting better or worse? trying to help families really think about this as around that 24-hour clock. Where are things potentially not going well? Where are things potentially going better? I think that's all really important information for thinking about what they want to do next in terms of treatment plans.
I will just raise my hands and stick a pin in that, because we often think of sleep as sleep for the night, but we forget sleep is a 24-hour process. And what I mean by that is the sleep that you have at night, we know from all of the work from the field, is strongly predictive of your waking day. And so it's not just about retrospectively when you wake up, did you sleep well and what was your sleep like? It's also that sleep that you've just had is also going to dictate how your waking day unfolds. And therefore, if you once again only measure sleep and ask about sleep, you're kind of missing half of the entire equation, because that's a lot less meaningful without knowing, well, then how did the sleep that I've just asked about and measured produce any benefits or deficits in your waking brain function throughout the day? So I think that's so critical to know. And especially because sometimes, even with insomnia now, a component of that is you may not necessarily struggle to fall asleep. You may not even report having difficulty staying asleep. But insomnia can also be a situation where you just don't feel refreshed and restored by your sleep during your waking day. And therefore, measuring the waking day and sleepiness is key. I also just want to point parents, if they do want to fill out a sleep diary as they're starting a new medication, to do exactly what you're suggesting. If you just Google sleep diary PDF, there's probably lots of them online. I think the National Sleep Foundation, if you were to Google sleep diary, National Sleep Foundation, I think you can get a really nice sort of PDF download there too. Coming back to it, and this notion of treating and trying to help the child with sleep, or the adolescent in particular, that I want to focus on here. One of the difficulties that I've always thought about, and sometimes when we work with clinicians for sleep interventions, is just how receptive people are. You can say, look, we've got this great cognitive behavioral therapy tool, or this great electrical brain stimulation tool. And, when we use it in the lab, it works really well. But if you don't have someone who wishes to be complicit with the treatment, with the intervention, it doesn't matter how wonderful your new treatment is if people are just not going to adhere to it. So in your work, how receptive are adolescents to interventions focused on improving their sleep? Are they interested? Are they motivated? What is your experience with that degree of desire to engage and their motivation to do this?
Such a great point. With any intervention for adolescents, it depends on how well we connect with what motivates them. We know that sleep is vital to supporting a lot of things that adolescents care about: positive mood, athletic performance, good grades, and interpersonal relationships. On the other hand, there are a lot of demands on adolescents' time that are also motivating and compete directly with sleep. So, peers who are up late and texting them, electronics, video games, and even homework. Adolescents can absolutely be motivated to improve their sleep, but before going straight to any behavioral sleep strategies, we first find that we need to do two things. So, number one is educating adolescents about how sleep supports them in doing the things that they care about. And two, helping adolescents find their own internal motivation to change. It can't be because a parent wants them to get better sleep, and certainly not because I, as a provider, think that they should. It really does have to come from them.
What I find impressive about that is, and it's something that I've once said before in speaking about when people ask me, what would you suggest in terms of how to optimize sleep or any recommendations? There's no point in just feeding people rules that do this, do that, and don't do this, and don't do that. people don't respond to rules. People respond to reasons and not rules. And so I think it's so important, as you said, to provide education as to this is what we're planning on doing to try to help you with your sleep. But these are the reasons why it's important to change your sleep, because me just barking orders at you is largely meaningless. But if you give me context and you give me reasons and not just dictatorial rules, I think one's adherence becomes, and it's just what you're saying, becomes so much more powerful because you understand, and therefore your motivation is far higher because of the logic behind the reasons and not just the dictated rules. Speaking about treatment, then, and I think focusing here on non-drug treatments, we've already mentioned several times this thing called cognitive behavioral interventions. Could you say a little bit more for parents to dig deep into that, double click on it? How do you integrate cognitive behavioral treatments in managing specifically sleep issues and sleep disorders in ADHD?
Interestingly, cognitive behavioral treatments for insomnia and those for ADHD largely share the same underlying framework. In both cases, we help adolescents improve their functioning by changing what they do, that's the behavioral component, or how they think or interpret situations, that's the cognitive piece. If we think about ADHD as that 24-hour disorder, as we were just mentioning, then we need to be helping the individual learn skills that they can apply both during the day and at night. For example, a behavioral skill for ADHD encourages the adolescent to create routines that help to organize their days. So a consistent use of a calendar and to-do list, figuring out specific places where you keep your belongings so that you're always able to find them. Similarly, behavioral sleep medicine strategies help the individual to create routines to help them sleep. So doing the same 3 to 4 sleep-promoting activities in the same order before going to bed, and setting regular bed and wake times. So these are largely the same skills. We just need to integrate them as providers into a streamlined message for the person so that they feel confident implementing them regardless of the time of day.
Let me come back to something we spoke about earlier, which has just tweaked my mind. You were mentioning how the deficits in slow wave sleep were not just present and measurable, but they were functional and consequential because they were predicting next day cognition. So perhaps just to add the opportunity for you to sort of fill that component out a little bit more. If I were a parent with a child who has ADHD, what would be some of the key findings from your research that I should be aware of in the context of how the sleep dysfunction of my child could influence the neurocognitive outcomes in the context of an adolescent with ADHD?
So an interesting thing about ADHD is that it is a highly heterogeneous disorder, meaning how it looks and how it is experienced for different individuals varies widely. One example of this is impairments in cognitive functions, which include things like working memory, risk and reward-based decision-making, complex attention, and response inhibition. And so these cognitive impairments are common among children and adolescents with ADHD, but are not universally experienced by all individuals with this condition in the same way and to the same degree. So for parents, if they are seeing these kinds of cognitive impairments occurring for their child, the results of our work may suggest that evaluation for sleep problems, including insomnia, may be indicated. And depending on the results of that assessment, that a behavioral intervention may need to be a key part of a holistic treatment package to improve daytime functioning for their child.
A sponsor of today's show is Inside Tracker, which is a service that comes out to your home and they will analyze your blood and your DNA to know precisely what is going on inside of you. Hence the name Inside Tracker. they look at your blood, your metabolic signals, your hormonal health metrics, and then they give you a personalized, actionable set of lifestyle changes in response to that readout. And the goal there is to improve your health. I was looking and informed they have some new cardiovascular and new hormonal biomarkers that I'm particularly interested in. One that I'm focused on is something called ApoB, which is an absolutely critical heart health measure. And I get it done now with them somewhere between 4 to 6 times a year. Why? Well, my family unfortunately has a strong history of cardiovascular disease, so I am checking that pretty ruthlessly. And by the way, I do buy the product myself out of pocket. I don't want to fall prey to any of those trappings and undue incentives. Although, with full admission, I still use my own discount code that you can use to get some money off. And that code for you is insidetracker.com/Matt Walker. So just go over to insidetracker.com/Matt Walker. And again, if you want to get that discount, it is insidetracker.com/Matt Walker. Thanks very much. So based on the potential relevance and the impact and the importance of sleep in maintaining, serving, and supporting cognitive brain function, if parents are seeing some of those challenges in the cognitive functioning of their child, don't stop at thinking, what can we do during the waking day to try to help that child? But maybe also consider that there is something, if that's all you do, that you're missing in your treatment equation, which would be, yes, it's great to think about the waking day and maybe exactly how to create regimens behaviorally or even pharmacologically to help the child, but don't ignore the night. Make sure that you can ask your team about trying to assess a child's sleep, or how could I as a parent be assessing their sleep? And if sleep is an issue, maybe there is a diagnosis of a particular condition, then how can we help treat that? Because if there are sleep problems, they're more than likely going to be consequential to the cognitive function of my child during the waking day. Is that sort of fair to say as sort of as a message for parents to maintain no pun intended, but to maintain vigilance about this thing called sleep at night for their child?
Yes, exactly. I think coming back to this sense that ADHD may be best thought of as a 24-hour disorder for many individuals. And I think to your point, if we are focusing only on treating what we see during the day, we are missing a very big opportunity to treat the other part of the 24-hour period, which may be very important. Sleep is very important for cognition and for functioning. And so I think considering across that clock, those 24 hours, is going to be very important for a lot of children and adolescents with ADHD.
I want to be very sensitive to and respectful of your time, but I would be remiss if I didn't ask perhaps about the digital revolution and our relationship for all of us, but in particular, children with and adolescents with ADHD and technology. Of course, there has been murmurings from the sleep field that, of course, the invasion of technology into our world and often into our bedrooms has been, if you look at some of the data, a detrimental force. Now, exactly how and why it is still being resolved. And we've spoken about this on the podcast before. But I am, I think, like you, not someone who wants to throw the baby out with the bathwater here, because that genie of technology is out the bottle and it's not going back in anytime soon, no matter how we wave our hands about it. So before speaking about how technology may help in a therapeutic intervention context, because this is another part of how brilliant you are in your work, but is there anything to start with that you know about regarding how technology use in children with ADHD could be or can be detrimental?
As you say, technology is ubiquitous these days for everyone, but especially for teenagers. So teenagers tell us that they sleep with their phones under their pillows so they don't miss a text. We even hear from teenagers who sleep while on video chat with their friends. Like the video chat is on throughout
Wow.
the night and they can hear their friend snoring across town. So technology at night is a sleep thief. It either directly replaces sleep. For example, the adolescent who is messaging a friend or playing a game at night isn't sleeping, but it can also indirectly impact sleep. For example, technology can be emotionally and cognitively stimulating, which can increase that physiological arousal. In addition, as you may have talked about previously on your podcast, interference of the light, the bright light with a circadian rhythm, and that can also impact sleep. So even if this teen does have enough sleep pressure to fall asleep, if there is this increased arousal or interference with circadian rhythm, they may not be able to do so. And in ADHD, all of these processes are magnified and amplified. So one thing that we know from research in ADHD is that youth with the condition are at higher risk for technology overuse compared to adolescents without the condition. And part of that has to do with one of the aspects of ADHD related to impulsivity. So teenagers, many of whom may have kind of that impulse to continue using technology at night. For an adolescent with ADHD, it may be even more difficult to turn that off or to put that technology away. And then those adolescents, as we've been talking about, are also at higher risk for sleep problems. And so I think there is a real risk of that kind of vicious cycle between technology use and poor sleep, particularly for those adolescents with ADHD.
And of course, all of us, based on these devices, because they are fiendishly well developed and curated to be essentially attention capturing. They are after our attention economy inside of our brains, and they do it very, very well. There are some very smart people behind this for creating that attention capture. But what we're hearing here from you is to say that, yes, we're all vulnerable, but children with ADHD, because of some of the challenges that they face, may be especially vulnerable to some of these challenges with adherence of abstinence or sort of resisting the impulse. And we already know their sleep by nature is fragile and problematic. And you layer on top another sleep downgrading force called technology. Gosh, what a challenge. Nevertheless, thinking about silver linings here, and I think this is another, as I said, a part of your work that I find fascinating, but how do you envisage the future of technology and sleep research? And could you tell me a little bit more about some of the digital interventions that you've been thinking about or even developing for managing sleep irregularities in adolescence and where that could go for the future? I love this American term, which is turning lemons into lemonade. So we've got the rather bitter tasting lemon of the current state of affairs with digital technology. Tell me a little bit more about the lemonade that you've been making.
So technology is certainly, in a sense, a double-edged sword when it comes to sleep intervention. So we were just talking about, as you say, that bitter lemon, where technology at night tends to create more sleep problems. On the other hand, we know that access to behavioral sleep interventions is limited. There are only so many providers, and in general, providers tend to be located in certain communities. For example, those with large medical centers. So technology can provide new opportunities to increase access to evidence-based behavioral sleep treatments, and digital formats of CBTI for adults with insomnia have had quite a bit of success. And so in one of our ongoing studies, we have worked to develop a sleep app that helps adolescents create and adhere to a more consistent, regular sleep schedule. And we will be looking to see whether improving sleep regularity through engagement with the app also improves psychiatric health. Now, during development, we spent a lot of time learning from adolescents, caregivers, and pediatricians about how to design an app that would be most helpful and engaging to teens. And one thing we definitely heard was that we need to make sure the adolescent is not using the app at night when they should be sleeping.
It's interesting. I love the fact that you actually went to the source, because it would be so easy for us as adults with all of our, especially with our scientific biases, to make assumptions about what it is that would work and work for them. And as the phrase goes, assumption is the mother of all. Well, you don't need to finish the sentence, but it's usually not good as an outcome. You didn't do that. You resisted that urge and you asked them, because what you're doing there is firstly finding these individuals where they live, and where they live is on their phone, point number one. And point number two is, how do I design on the basis of what you want? And then how do I almost Trojan horse fit into what it is that you want, this thing called cognitive behavioral intervention? I think it's absolutely genius. Tell me then, and this is so not fair to the audience, but when I have brilliant minds on the show, I'm always just fascinated by their own vision for the future of sleep research. So, as best as you can tell, obviously, sometimes in academia, because publications are still about to come out, they've not yet been published, and there's all of these embargoes. But what's next for your research, Jessica? Well, are there any new projects, new directions that you're especially excited about that you could at least discuss here? Any sort of teasers? Give me the Netflix trailers as to what could be coming down the pipeline.
One piece we're currently interested in and considering is the optimal time during development to intervene regarding sleep for individuals with ADHD. So one of the great things about sleep is that we can identify sleep problems and have success in treating them across the lifespan. On the other hand, for many psychiatric conditions, including ADHD, we know that early intervention, for example, in the toddler or preschool years, can improve the trajectory of symptoms and impairment over the life course. And in my adolescent ADHD study that we've been discussing today, we asked parents to retrospectively report on sleep problems for their children during the toddler and preschool years. And fascinatingly, parent reports and ratings of sleep problems in the early years were associated with the reduced slow wave activity in adolescence while they were in our study. And so to me, this suggests these sleep problems may be present early in life. And so how great would it be if we can catch that and intervene early? So right now we're developing and starting to get ready to evaluate a behavioral sleep intervention for preschoolers with elevated ADHD symptoms to see if we can improve not only sleep, but potentially some of these ADHD symptoms early in life. So this is early stages here. We're working on it, but I'll let you know how it turns out.
Gosh, and so you will then track those individuals, then longitudinally you'll start to intervene and see, has that intervention essentially changed the trajectory of where it is fairly clear based on the early symptomatology that they would be heading. You would in some ways continue to assess those individuals over time as you're administering this intervention and see if that changes. Tell me a little bit about if that's the way that you would be assessing it. How long would you have to do that for? And how long would you be administering the treatment across that longitudinal design?
Yeah, so this is actually just step one, although I think absolutely the vision. And so right now we're kind of focused on, can we do this? Can we develop an intervention for these kids? Is it acceptable? Does it seem to be effective in the short term? But, I think the really interesting thing about ADHD is that the literature largely shows that trajectories can also be pretty heterogeneous. So individuals with ADHD, some really show persistence of symptoms over time. Some seem to get better as they get older. We call that remitting ADHD. And for many individuals, they seem to have waxing and waning periods where the symptoms seem to be greater and more impairing at some time points and less at other time points. And so, one thing that I am really interested in, and if I can get all of the funding to be able to do something like this, would be to follow people longitudinally and to see what is the role of sleep in these patterns over time in terms of the symptoms and impairment. Again, I have a hunch that sleep is important here, but we really do need to do more work in that area to flesh it all out.
That's so interesting. So that's something I was not aware of, that there is this waxing and waning across time, that things can get better for a little bit. They can then perhaps deteriorate a little bit. And obviously, if that's happening, there is a biological, physiological basis for it, even if it's environmental forces that are changing and causing that variability. Even if they are external, they're going to be played out through the mechanism of internal biology. And it's very interesting to think that maybe one of the internal factors that could be causing that type of variability, which must be so challenging for the parents. My child is getting better and finally we're coming out of this. And then my child seems to be getting worse. And if sleep is a component of that, gosh, that would be so powerful. So thank you for sharing that. And I love this idea of intervening early. It almost reminds me, in terms of an analogy, that as a plane is taking off, let's say on a long haul transatlantic flight, as they're taking off, even if you were to just take off 2 or 3 degrees in the wrong trajectory as you're taking off, the ultimate place where you end up after 11 hours of flying is very, very different in terms of location, even though it was so subtle to begin with. So what I find very exciting about that notion of, can we develop it and can we administer it, even if it's just in the short term acutely? Maybe that's all that needs to happen to tweak back a couple of degrees onto the correct trajectory, and the destination of outcome is going to be more favorable as a consequence. My goodness. For anyone listening who could be involved in making the decision to fund Jessica's work, fund it. Just fund it. It's just so important. Please, please, please fund it. Oh, Jessica, we've run out of time. Thank you, firstly, for taking the time to speak with me and share all of this knowledge. I know this is going to be a podcast that is going to be very, very popular based on need and demand. The second thing I would close with is just an affirmation of gratitude for all that you do and for who you are in terms of your work in the field of sleep and what you do for your patients. Thank you, Jessica. Thank you so much.
Thank you so much for those kind words and for having me. This has been a lot of fun. I appreciate it.
Okay, folks, there you have it. I hope that this has been helpful. If you have any additional questions, we will be obviously announcing this episode on social media, but feel free to feedback to me with any questions that you have. And if we get enough additional questions, it may be that I can then tweak in terms of an intervention, another appearance of the wonderful force and knowledge that is Jessica back onto this show. Jessica, thank you so much again. And for everyone listening out there, thank you for tuning in, for listening to the podcast, supporting the podcast. I will simply say, take care, good night, and above all, I do hope that you have some restful sleep. Thanks very much. Take care.